So, good evening, everyone. Uh, Welcome to the last webinar that we are proposing to you for OIS. And this webinar is a little bit different from the others. We are not only focusing on biomechanics. There will be very much clinical, hopefully. And it is usually a topic that is very much attractive for a lot of orthodontists. I will try to discuss about TADS and skeletal anchorage by the point of view of someone who is giving an extreme importance to the biomechanics we use, so that the TADs have to be just part of a biomechanical system. So we are just starting this lecture, which can be very long. Actually, I mean, I've given this course even for 6-8 hours, so I have to compress it quite a lot to make it in a couple of hours. And so I'll try to focus on hopefully what are, I think, the most important thing here. So first of all, it's important to focus on TADs, but TADs are nothing else than a way to increase the anchorage capabilities that we have with our orthodontic appliance in our treatment. So first of all, let's define the anchorage. I mean, those who have followed my previous webinars know that we have discussed this when we have been talking about equilibrium. We talked a little bit about occlusal, the role of occlusion in anchorage. Anyway, my definition of anchorage control is the capability of maintaining unchanged the position of the teeth that we don't want to move during the whole treatment or maybe during one stage of treatment. So we need to have control. It is very important that we are not moving all teeth without control. There must be some teeth we don't want to move, and this is our anchorage unit, reactive unit, and some teeth that we want to move. So in this way, you those who know me a little bit understand that, for example, I don't like the approach of starting a treatment using an alignment night eye arch, because this means that you're moving every tooth, and most likely in most of the cases there are some teeth that you don't want to move. So this is the definition of anchorage. And if you go and have a lecture about anchorage, nowadays everyone is just speaking about TAD. TAD is very important. They represent a revolution in our profession. But anchorage is not only TADs. Okay, so this was a search that I have done on PubMed some years ago, I think 2 or 3 years ago, and you see there are tons of papers regarding TADs. So I'm not the only one who's speaking about anchorage, skeletal anchorage. And of course, in 2 hours I cannot cover all possibilities that we have using skeletal anchorage, but I will try to give my opinion, let you see how I'm using TADs, knowing very well that I'm not going to cover everything that has to do with skeletal anchorage. Well, one thing I want to start saying is that the impact of skeletal anchorage in orthodontic has been tremendous, really great. I mean, I can tell you because I've been practicing orthodontics for half of my time, half of my profession before TADs, let's say before the year 2000. I started to use TADs probably around 15 years ago. You know, at the beginning it was just a few attempts, and then more and more and more. And I've seen a complete change in our perspectives. I give you an example. Molar intrusion before the year 2000 and after the year 2000. This was a search of with the term molar intrusion before the year 2000, and there were 8 results. By the way, one of these papers was mine together with Professor Melson. So this means that there were very, very few possibilities of having a molar intrusion at that time. This was considered an extremely difficult kind of movement. And this is the paper I had published. This was in '96, and definitely we didn't have any chance to use TATs. So to make this kind of intrusion was quite a complex stuff. We needed to use occlusal forces, we need to use complex appliances, and very few people were able to do this kind of movement at that time. But now if you do the same search, molar intrusion, without the limit of searching before the year 2000, from 8 papers you got to 110. And this search was probably done 1 year ago. So now everyone is doing molar intrusion. So TATs have changed our work, and everyone has the possibility of learning to use TATs. If I was giving this course about TATs a couple of years ago, so you see this period 2 years ago, and just before going to the lecture, I just make a search on the internet. Is there any course about TATs in Italy where I live? So in those days in November, there were available 3 courses about TATs that I could attend. So everyone is speaking about TATs. Is probably one of the most attractive topics. So I hope that I can make an interesting lecture for you, but for me it is very, very important that we integrate the use of TATs with rational biomechanics. This is really very important. So let's say a few things about history of mini implants, but I will be very, very quick. I mean, things started here actually with I wouldn't consider all this, but the first thing I remember I had some ideas about Skeletal Anchorage was by Gene Roberts, that I know personally. Is a person who has also been working with Professor Burston, and he was using Branmark implants as Anchorage. That's very interesting, because that was probably the first idea to have a different approach to Anchorage. And it's funny that sometimes I still have problems with general dentists that when they know, I ask them, please put an implant first, they start orthodontics so I can use it for Anchorage. And they're really scared because they are afraid I'm going to spoil their job. So please consider that orthodontics has no possibility of creating problems to a Branmark or any kind of prosthetic implant. So things started, as far as I know, around this year. I mean, I was very lucky because I knew personally all of these 3 guys. Antonio Costa is an Italian orthodontist who is a few years younger than me, and he also followed some of my courses, biomechanics courses. I've been teaching biomechanics since 1990, and he was working with Raffaini. Raffaini is a very famous surgeon. Probably you know him because he is now participating very much to courses by the FACE group, together with Professor Cocconi, also from Italy. And these 2 guys, Antonio Costa and Mirko Raffaini, tried the first time to use a screw that Raffaini was using in surgery to get some Anchorage in orthodontics. So Antonio had the idea to place a bracket on top of this screw for surgery. And later on, I introduced Antonio to Professor Melson. And so this was happening maybe 97 or 98. And in 99, they just published the first paper about TADS. From then on, we had tons of papers, tons of publications, courses, and everything. So, I mean, of course, it's impossible to let you know everything about TADS. So I will try to tell you a few things that I think are really essential, and when are they needed, where can we place them. Of course, here there is a great variability, and my preferences might be different from other people. How they are inserted, this is the simplest thing, and most important, how can we use them. So remember that if you want to use skeletal anchorage at most of its potential, you want to use it 100%, you need to know a lot about biomechanics. If you just know how to place a TAD and you don't know a lot about, and you don't know well biomechanics, well, you're using very little of it, and maybe you can even do damages by using TADs, even more than you don't use them. So please consider biomechanics as the most important asset in your orthodontic potential. So please study biomechanics. I'm advertising my book, but there are other sources that are very good. I also would suggest that you consider the book of Burston and Choi, which is an excellent book as well. This is, as far as you all know, that this is an online textbook. But if you just know how to place a TAD, and you don't know how to work, and you don't know how to use biomechanics, you are just doing damages. This is a treatment I saw several years ago, and this patient was treated simply for retraction after having extracted his tooth using TADs. But this doesn't solve the problems of a bad biomechanics. She came to my office with a lot of problems and pre-contacts here and only contacts here. She had TMD, she had teeth that were very mobile, and this was the problem with biomechanics. So the placing a TAD here is not solving everything. It might be even worse. So in this case, before going on, I had to recreate occlusion and let the patient start chewing again. So she had to rest and get better from her TMD. So don't think that just to use a TAD is the solution for everything. TAD is just a piece of the biomechanics, and you need to know it within biomechanics. So here I have a case of, I'm always getting things from the internet. I mean, those who have followed me in Paris, you know that I've taken a lot of material from the internet to see strange things, and I didn't have the time even to show all of them I had. But, here is important to understand that we need a TAD, where we need a TAD, and it has nothing to do with the technique of using a TAD. This has to do with biomechanics. For example, this guy start saying that he requires these two moments to correct the position of this two premolar, but this is wrong. Actually, it requires this moment plus a force and plus a force here. And for sure, it doesn't require this force that brings the lateral in this direction. So, I mean, this information has to do with general knowledge of orthodontic and biomechanics. And if you don't know it, You don't know how to use, when to use, and the result is here. The two premolars have rotated, but you have no space for a canine here, which is above here. And the midline that was on now is off. So you know biomechanics and you know when to use it, why you need it. So I don't want to stress with this because we have so many things to discuss. But then I see people that are discussing about little things about, well, how I should place the bracket, and maybe we can do some little things, but they have really very little understanding of the whole thing. And even if a case like this is finished well, otherwise they wouldn't have published on the internet, we know that what happened is that these teeth were going back and forward, and this is not good at all. So we have to think to the needed force system, and then we have to see whether we need anchorage or not. Okay? So, for example, this is not a case of mine, but it's okay. I mean, there is a good idea of biomechanics. If the idea is just to bring this motor forward, we are placing two forces at this level, which is higher than the bracket level. So we hope that the force is placed at CR level, and there is a TPA, transpontal bar, which prevents rotation. So that's fine. I mean, that's not the way I would do it because I don't think we need a continuous arch wire here, but that's fine. I mean, it's someone who has a good knowledge of biomechanics. So no TADS without biomechanics. Forget it. Okay? So let's start saying, when do we need TADS? So you don't have to use TADS every time. You need to use TADS when your available anchorage is less than your needed anchorage. This can be considered numbers. I mean, what is the needed anchorage? Is a force, or is a force in a moment. We can compute this if you make the analysis of the force systems. Oh, I understand that for you this thing can be a little bit complex and maybe you're not used so much, but I will give you a little example. Let's assume that we need to apply this force and this force to this unit here and this unit here. Forget that here you see a TAD. Just consider that these are the two forces we need to apply. This 100-gram force intrusive on this posterior teeth and extrusive force of 50 grams. Is it possible to make this movement without any kind of anchorage? The answer is no, because these two forces are not in equilibrium. In order to be in equilibrium, we are missing this force system. That we can apply this force system to another tooth, and we can say, this is what you see here is the needed anchorage. But then we have to ask ourselves, will the canine have enough available anchorage to stay there? I mean, usually the available anchorage is given by occlusion most of the time. And a canine cannot withstand this force system for sure. So here we can say, no, we don't have enough available anchorage for the needed anchorage. So, yes, we need a TAD. So that's the way I think, and I try to transmit to my students, think in terms of forces and moment that are needed. We will go back to this when we'll see cases. So let's start talking about possible insertion sites. I'm going very, very fast because in 2 hours I have to really make a very quick lecture. So I will tell you not the best, but those who personally I use more. And then I will tell you why I use this insertion sites more than others. Okay, for me, the routine position for TADs is between the roots. I know very well now that there is a quite new trend of using TADs in different places, in the palate, in the mandibular shelf, in the zygoma. And I'm not saying this is wrong. I'm using this sometimes, but I will let you know why I prefer, as a routine use, to use intraradicular position of TADs. So this is a nice insertion in the case of mine. So just by chance I had the CBCT after I had placed this TAD. I didn't do the CBCT for this reason, because of the TAD, but completely for other reason probably. But I took the chance to cut the TAD here in 3D, and here you see my TAD, which is an area with no only bone here. You see that we crossed the buccal-cortical bone. We are close, but we are not touching the palatal cortical bone. Here we see the TAD, which is quite nicely inserted between those two roots, and we see the same here. So this is a very nice insertion. Is it very difficult? I mean, of course, I'm not doing a CBCT every time I'm using a TAD, but I believe that this is a very routine placement of the TAD, and I don't need to have an X-ray to do this. You can simply palpate the position of the roots here and have a very good idea where they are and how you could place the TAD. There are very few rules in order to place the TAD. Maybe, of course, you will have an X-ray. You will have a Panorex maybe, and you see whether the roots are parallel. If the roots are parallel, you should have space for placing a TAD between the roots. But of course, sometimes you can have some problem like this case. And here we have a second premolar, which is inclined in this way, so the apex is to the distal, and the space is really too narrow to place a TAD here. So what do we do? Well, most of the cases, well, you can consider that if this space is closed, this one is larger than usual. So very often you might say, well, if it's not strictly necessary that I place my TAD here, I will place it here. I have a lot of space. Otherwise, if for some reason, and we'll see when, you do need to place your TAD between the 6 and the 5, just wait a second. Correct this inclination first, and after a couple of months, you will place the TAD. So where should we place this TAD? Here you see that there are some information, and probably are going back to see this these things later. But the important thing is that, for example, the height of placement of the TAD depends on the limit between the attached gingiva and the mucosa. So this is not the same for all patients. It's not the same for all teeth. But if I have the gingiva up to here and this side is non-keratinized, I will need to place the TAD at this level. I cannot go up here, and it doesn't make sense to put it here. So I have a very good guide on where to place the head of my TAD. Usually you make an insertion which is directed a little bit to the apex, as you see here. Not very much. Maybe 15-30 degrees is okay. And it's not very common that you can have a bicortical anchorage. And this would be nice, especially in the upper arch, but we should use quite long tads. I'm not using very, very long tads. And in most cases, the anchorage and stability, which is given by one cortex, is enough, provided that you have at least 1 millimeter of this thickness. So the thickness of the cortical bone is probably the most important factor in making a TAD stable or not. For this reason, a lot of people have moved the use of TADs from an interradicular position to other positions where they might find a thicker bone. So I don't blame them for behaving differently than what I do, but I will show you that I have other reasons for keeping working with the TADs placed between the roots. Here you see that in the mandible, usually we have very little problems, because you see the thickness of the cortical bone is, these are average that we're taken by a study, a research on it, is usually much more than needed. So if you if you lose a TAD in the mandible, it's not very likely that it depends on the lack of bone, but probably there are other factors. While in the upper arch, this is a great possibility. Here are a couple of images, and here is a good cortical bone. This shouldn't give you any problem. And here is a cortical bone that you don't even see it. Now remember that the CBCT has a minimal resolution of 0.3 millimeters. So if the cortical bone is below this, you don't see it. As here, I can't see anything. Where is the cortical bone? I can't see it. Do you see it here? Maybe here I can see it. So in this condition, the cortical bone might be there, but your TAD placed there will fail. So since you're not doing a CBCT every time you place a TAD, know that there are a number of cases, especially in the upper arch, where your TAD will fail because you don't have enough bone. Of course, if I've done the CBCT before placing the TAD and I see this, I would just say, okay, forget it. But we're not doing the CBCT for every case. So we don't know how much is the bone, we just try it, and consider that in the upper arch there are a good number of cases where this fail, and I wouldn't consider this to be my fault. It happens. So why do I like it so much, these things, in spite of the fact that there are some problems, especially because we might not have enough bone for stability? The reason why is that with TAD in this position, I can do a lot of things. If they stay there, then I am becoming a sort of Superman of orthodontics. I can do many, many things. And I'm free to do them. I'm not obliged to use a specific appliance. Think to the benefit system. It's very nice, very effective. But you need to buy every single piece from this system. You have really little bit creativity. You need just to buy something which has already been studied for you. Here, once I have the TAD, I can do whatever I like. I can use my creativity, do completely different mechanics, And this applies in most of the cases, because we're not losing TADs in 50% of the cases, maybe 80, 85. So in the majority of cases, we can use this very nicely. For me, placing the TADs between the roots allows many things. And as we will see, we can use it like this, which is an indirect use. So the wire, there is a connecting wire between the TAD and the molar, and then this molar becomes my reference. It's a tooth that is probably not going to move, and I can use it for many different things with different kind of biomechanics. Here is a TAD which is used in two ways. Here is connected here, and here is bonded. So this is indirect. But here it's a direct way. So I'm applying directly the force to the TAD. I'm applying this kind of force because this cantilever is like this. And so I'm applying a force to move this molar to the distal. Is this okay? Well, it's not okay. We need probably something different, because this force alone is not okay, but because it would create a rotation of the posterior teeth. But then now you are in control. If you know biomechanics, you know what you have to do. I mean, you have applied the force here, and then you start thinking, well, what do I need to prevent the rotation? And we will discuss about this when we go more to the clinical cases, and this is just a very quick tour about the different insertion. As I said, one of the limits is the gingiva. I mean, in this patient, we really didn't have attached gingiva here. So this is the limit. And if you place a TAD here, you will have a lot of problems. Inflammation and bacterial problems here. In this case, you get 50 to 80% possibility that you're going to lose the TAD, and it gives a lot of problems for the period it stays there. So just avoid that. If you really have this position, try to think if there is an alternative rather than put it there. And usually there are many possibilities. If you know how to use biomechanics, you can figure out a completely different solution, and you are not obliged to place the TAD in one single place. Palatal, of course. In the palate, usually we have more bone in the average than in this area here. So sometimes when I have problems with intraradicular TADs, I move to the palate. And the reason for this is that the amount of bone you have in this area or in this area is usually more than the bone you have here. The cortical bone is thicker, is denser, so I think is a very good alternative. My problem with this is that either you use a system which is ready-made and you have little possibility of changing it, and I'm again thinking to the benefit system, which is fine. Is a great system. I mean, he has a lot of success and it works. But if you want to change something, because remember all cases are different, it's a little bit difficult to work with it. So I'm not using it for this reason. I prefer to build up my system, and to build up my system using TADs in the palate is a little bit more complicated. It's not impossible. In fact, I'm doing it. And I share with Benedict Wilmans and with many others, the idea is that this is the area where you should place TAD in the palate. Here you have no problem because all the soft tissues here are keratinized, so you have no problem for this reason. Usually you have more bone. I've heard people saying that they prefer not to place the TAD like I've done here, just in the middle of the palatal suture here, because they say that when you place a TAD in this position, it might find a lot of connective tissue. So they do prefer to place it maybe here. I'm not sure. I've been placing TADs mostly in the middle with very little problems, but my numbers are not so high. I mean, as I said, my routine placement of the TADs is between the roots. And we'll see some cases where I've used the TADs in the palate. It was always, a second choice after some failure from the intraradicular. Now, I mean, everyone is talking about MARPE, the use of TADs to make palatal expansion. And here you see this applied to an adult. This patient is a female, about almost 30. And let me see. Okay. And you see that we have opened the space and this arch will be broadened. I'm not using this so much. I have done a few cases. It works. This is the Womb system, and it's okay. I had some problems because these TADs, they always go through to the nose, and patients have a little bit of discomfort. But it's okay. If you really think that you need to place make a palatal expansion with this, this can work. I'm not using it so much. I mean, I've seen a lot of colleagues that are really crazy for using this kind of appliance, and they use it in many cases. I do think that we can do very nice expansion using other things like TADs. At the end, if you're using the right force system, you can expand nicely an arch even without using TADs, because it's not really a matter of anchorage here. Here you see that the TADs that are going in the nose. In fact, the first time I placed 3 or 4 cases in this kind of appliance, and now I'm aware of it. But the first time I was not prepared, and when I was inserting the TAD, I did the anesthesia. But of course, my patients say, "Oh, my nose is hurting," and so, what? Yeah, I mean, it goes up there, and I actually am not very good in nasal anesthesia, so this is a little bit of a problem. But anyway, it's a little bit of discomfort and nothing which is really important. Here you see a TAD that I use in the palatal. If you place a TAD here, which is one of the area which is recommended, the T shape, this could be very good for direct use, and we'll talk about this later. Not so good for indirect use, because this, or even if you do this, wire for connecting the TAD to the teeth is usually a little bit too long. So other possibility of insertion, the retromolar, I've done it a couple of times, but of course you need to have space posterior to the last molar. So of course there's no way to do it when you have the third molar, and often there's no way to do it when you have also the second molar. In this case, actually this is a second molar, but the first molar was already gone, so here I had a lot of space and I could use the TAD here. So this is just an exceptional possibility. The buccal shelf is biologically is great, but I find very difficult to use it. It's not as easy as other system, And you need usually longer TADs than those I use. We'll see what I'm using. And so also this for me is not definitely routine. I've done it a few times. And another way to do it is the infrazygomatic crest. Also here, you go up here in this area. There might be, usually there is more bone than in this area, but the problem is that you need very long TADs. You need very long TADs here because the TAD must be sticking out of the mucosa, because here you never have a gingiva, and so there must be the TAD coming out for 3 or 4 millimeter out of the soft tissues. Actually, this is something that I've never used, and I'm not very eager to use it, although I have some very good friends that are very happy with it. So I'm not saying don't use it. In this lecture, I will tell you what I do and why I do it, and so then you can take your decision considering my experience, which of course is not the experience for everyone. Very quickly, success rate of TADs. I mean, we're talking of numbers that go from 90 to 84, 85, maybe 80%. But we have to accept that there are some TADs that will fail. Reasons for it is in the upper arch most of the time is that you don't have enough cortical bone and you didn't know it. So it's not, I wouldn't say this is your fault, and this is the case. I mean, if the thickness of the cortical bone is 0.5 millimeters, 90% is going to fail. If it's 1 millimeter or above, you have good chances to have it for a long time. The other reason which might be caused the loosening of a TAD is the inflammation. Of course, patients have to keep the TAD clean, and you have to extract them to do it. But it's very important that you place your TAD within this limit. I could have placed it even here, but if you place it here, there is no way that you can avoid inflammation, because in this area the patient defense are not good enough, so you will have a lot of inflammation here. And so try to avoid to stay up here beyond the limit of attached gingiva. People talk about root proximity. What does it mean? This is something which is true, but is it a problem? For example, let's imagine that you don't have this tooth, and here you have a TAD, or maybe you have it here. When you move this molar in this direction, you will have resorption of the bone in the area that towards the TAD, and at a certain point, when the root get closer and closer to the TAD, you won't have bone anymore, and the TAD will fail. Sometimes it happens, but you can predict it. This is not a failure, it's a passage of your treatment. Maybe you had used the TAD for some other reason, it was here because you need it for some other reason. I have no idea, but I'm just saying. Then you use it to move this molar forward. At a certain point, you have to take it away and maybe place it here. This is not a failure for me, it's just a step in your treatment. Another reason for which a TAD can fail is the overload or incorrect load. I mean, considering that the stability is given by, in the very first period, just by the mechanical features of the cortical bone, I mean, usually you should be very careful not to give a very large force, because if you apply 300 grams of force, even if you have a good cortical bone, you're going to have microfractures of it, and everything is going to get loose. So the force should be within certain limit, and the limit at the beginning is 50 grams, maybe a little bit more, but not very much more than this. After some months, at least 3 months, you can increase the level, but you cannot apply 200, 300 grams of force. I would say that you are, in this case, you have great possibilities to lose your TAD. The other thing is the incorrect load, because TADs, if the load is not too high, can sustain any kind of force but have problems with moments, and we'll discuss this in details. One thing which is important is that if you lose a TAD, you're going to lose it soon. And why is this? Because probably one of the reasons for which you will have a TAD loosening, which is the usually is that you don't have enough cortical bone, is going to give its effect right away. So if you don't have enough cortical bone, after 1, 2, 3 months, your TAD is gone. And this in some way is also good, because you understand the problem and there's no inflammation, and it's just a TAD comes away. I mean, okay, you say, well, I really have very little bone there, so it's not your fault, but it happens. So most of the losing, the dislodgement here, are happening in the very first period. A few suggestions about TAD insertion. I recommend my patient to have mouthwash with chlorhexidine for 7 days, a couple of times per day, and this is to lower the amount of bacteria in the mouth. And just before the insertion, they will have a cotton wad with chlorhexidine applied to the site of insertion for a few minutes. Which are the TADs I'm using? Well, probably most of you know that I have a very close contact with Professor Birte Melsen from Denmark. She has been my mentor for many years. Now we are giving courses together, and we have been teaching for many years together. We have been cooperating in the biomechanics textbook as well. So I'm using her TADs, and actually all my experience is using this kind of TADs. But I'm very happy with them. And I cannot tell, look, these are the best TADs. I'm not selling anything. I mean, my experience is with this kind of screws, and I can tell that I'm very happy with them. Maybe other TADs are as good as these, or maybe even better, but I have no experience with this. What I can tell you, that I've heard a lot of my colleagues and students that were using other kind of TADs, and they were not happy with that, and I told them, well, I'm using this system and it's really fine. And when they move to this, they say, wow, there's a difference. But of course, I'm not going to I have no financial interest, by really 0.0% of it. I don't take anything about financial. It's just my experience with this kind of system. Very quickly. These stats come in two. First of all, they are sold by American Orthodontics. If anyone is interested in buying this, I mean, these are marketed by American Orthodontic. They are produced in Germany, but they are sold by American Orthodontics. The company producing it is called Medicon, but you're not interested in that. They come in 2 different lengths. So probably we have another. Well, I'll tell you immediately. Then maybe there is another slide telling. These slides can be this part of the screw can be 6.5 or 8.5 millimeters. So when you want to try to get to the bicortical stability, try to use the 8.5, but this is not guaranteeing you that you will get to the other side. But if you use the 6.5, you are 100% sure that you will have only one cortex involved in the stability. Then a very good thing is that they are cutting very, very well. This tip is self-cutting, so you don't need to make a flap. If you have if you have reduced the bacteria amount, and never had big problems, because you don't need to have a flap, and this cuts very, very well through the mucosa, through the bone, and it's really a good system. The company says that you should drill in case of very thick bone, but actually in I don't know how many hundreds of TADs I've placed in the last 15 years. I have no idea. I could just tell you 500, but I'm not sure. And but I remember only a couple of cases where I was feeling that the bone was so thick that I couldn't go through, and in that case I took my drill and a burr, and I made a little bit of invitation for the TAD, and then I could go on. But just a couple of cases out of hundreds of them. So most of the cases are very simple. You just work as a carpenter using a screwdriver, and you go through as it was just the wood. When we do these courses with the practical part, we can use bone of animals and try to put it, and you see that even usually we use pig, and even if the bone of the pig is usually much more dense than human, we can go through it. It's a little bit harder than what we have in humans, but we can go through it. So this is not really a problem. They are really well cutting. Another feature which is important is that the neck can be shorter or longer, can be 1.5 or 2.5 millimeters, and usually when you use it in the palate, you better have a longer neck. But since the majority of the TADs I use are on the buccal side, most of the time I just need a short one. So in the overall, I would say that you have this two lengths of the part which is inserted in the bone, 6.5 and 8.5, two different lengths of the neck, and so it makes 4 types that I use. The diameter is coming in 3 different dimensions, and let me see if I find the one with all the numbers. So here is the length. Yeah, here is the diameter, and usually I'm only using this intermediate here. The 1.5 actually I think is 1.6. I'm not sure, but anyway, is the middle one. They say that you can use this when you have very narrow space between the roots, but I think that is not worthwhile, and then you have more problem of stability because this is too thin. You might decide to use this, but this is good only for the palatal or for the buccal shelf. So basically I'm not suggesting or recommending you to use this two here. Just buy this one, the intermediate. So the 1.5 caliber. The most important thing that you have to choose is the head. You can have the head with a hole. This is useful if you are thinking to make a joint here. I will show you what is the connection. This is just the pin, and this is the bracket. These are two brackets. This was the older version, now is not existing anymore. We have this one. And I'm only using the bracket head. So in the overall, I mean, with 4 kinds of TAD, you cover everything. But if you want to save money at the beginning, you might even buy a couple of them. So, as I say, the most important thing for me is the head, because with the head I can decide to do a very different thing. Here you can see very different use of my TAD. Here I have a Y which is very rigid. This is called a strut, is an engineering term. We'll see that. And so there's no freedom of this tooth to move because it's completely blocked by a very thick wire here. Here we're using a wire which is active like this and activated in this direction. So we are applying to the TAD this force, and we are applying to the molar this force. You could use just a TAD with the pin for this, but as you see, once you have a bracket like head, you can use it for everything. So there's no reason for me to have different kinds of the mini screw. The other possibility is that here I have a TAD and the wire is engaged in the bracket, and here you have to know a lot of things before doing this. You can use this wire actively to move the teeth. So this is passive. This is inserted into the bracket but is active. And this is, the TAD is just a point where you apply the force, but there is no engagement in the slot. But in this case, you could use a pin head, but with the bracket head you can do everything. So it's important to stress the difference between direct and indirect use. Very, very important thing. If you use directly the TAD, it means that you are applying a force to it. It means that most of the time you need to place the TAD along the needed line of action of the force. What does it mean? That if, let's imagine that I want to apply this force, okay, just forget all this. I want to apply this force to the premolar. Where should I apply the TAD? Well, along this line. So maybe here is not very bad, it's not perfect, but could be okay. So the line of action of the force is telling me where to apply the TAD, okay? So this is a very basic concept, but it's important. And as you understand, either you know biomechanics or you will never know it, because the needed line of action of the force depends on the movement you want to do it, and there is a lot of biomechanics to know before to get into this information. Okay? The indirect use, I'm not sure, but probably the way I'm using TADs the most, it's here you see it. There are many examples, but here in this case I have a wire which is engaged in the head of the screw and engaged into the TAD. Now what happens is that this teeth, because these are connecting together, are becoming my anchorage unit, and they are probably not going to move for no reason. So I can do whatever I want. I can use my usual mechanics, and here you see a T-loop for space closure, but I could use anything. So once you have created this reactive unit with the TAD, then you're free to use any kind of mechanics. I mean, I'm using segmented arch most of the time, so you can do a very different thing. But if you prefer to use a sliding mechanics to do this, I don't like it, but it's okay. I mean, you can. There are some problems with it, but they are related to biomechanics. I mean, your TAD is working in the perfect way. Direct use, remember, the force is applied directly to the TAD. Well, this is a picture we have seen before. This is a very typical thing. So you place an elastic or a coil spring, and in fact this is very typical, but I'm not using that much. I don't like very much to use a coil spring like this. Why I don't like it? Because this coil spring gives to me only the possibility to apply this force. So the force connecting the TAD to this bracket. But if I want to give this force, for example, I can't do that. But maybe that's the force I need. And in order to get this, I like to use cantilevers most than this kind. So you will see very seldom this kind of mechanics with the coil spring, because it gives to me a lot of limitations. While this, it's okay. I mean, now I will produce this force. But if for any reason I have to produce this force, or this force, or this force, I can do anything. And this gives to me a lot of possibilities. Now, whenever you're applying a direct use, you have to think to the line of action of the force. Now, I'm not going to discuss this very much. There's a little video that can give you an idea. I mean, here is a TAD, and I'm applying this force with the cantilever. You see the obliquity of this line of action probably makes me have a force which goes above the CR. Maybe not so much, but a little bit. In spite of the fact that the TAD is not above the CR. And this is very interesting, because in this way you can have more control of the apex of the root. Maybe, yes, there is a vertical extrusive force, but if the patient is not a high angle case, has good capability of chewing here, this might be not a problem. So let me see the video so you can see what is going to happen here. So this is an application of a force with a cantilever, and you can imagine that if your only possibility was to use a coil spring. Now let me go back, because this could be interesting. If the only possibility was to use a coil spring, well, you could have a coil spring like this, so this force. Or you say, well, you could use an extension and have this, but I don't think you can use an extension so high. So you see, the use of cantilever together with TADs gives to you a lot of possibilities, and so I don't use coil springs so much, as I said. So we're talking again about direct use of the TAD. I have to speed up, because otherwise you won't see cases, and I don't want to disappoint you on this. You can place forces in any direction. At the beginning, stay within this limit. Some time later, you can increase the force. 150 grams is really the maximum. People say 6 months should be safe. Sometimes I've done it also 3 or 4 months after insertion. But there are limits. You cannot apply any kind of any amount of force. I mean, there is a limit of the amount of force. While there's no limit for the direction, so you can apply a force in any direction and there is no problem. So you can always attach a cantilever or a spring or coil spring with a single point of contact to the head of the screw. There's no problem if you respect those limits. The real problem is the moment. What is the moment? Is when you have 2 points of contact of the system. Now, you will understand, how can I apply a moment to a TAD? In order to apply a moment to a TAD, you need to have an extension. I don't know if if I have this extension here, maybe you have a wire, and this could be the bracket, like you bring an extension here, and then you apply a force like this. Well, this force is, as you should know by now, is equivalent to a force in the moment. So I have a moment. So that's the way you can produce a moment, and the moment is produced because here you have a wire engaged into the slot, and you will have 2 points of contact in these two X I'm drawing here. So moments are sometimes very dangerous for the stability of the TAD, but sometimes are not. So it's important that you understand when you can apply moments or not. In this case, in this example, it's fine, for example. And which is the rule? The rule is that if you produce a moment that is within a plane, look at this plane. Here we are producing a moment like this. And this plane is parallel to the long axis of the TAD, there's no problem. Okay? So also in this way, if I apply this force, it's producing this moment in this plane here, which is parallel to the long axis of the TAD. So in this case, there's no problem. And here we have a little video that tells you how we can use moments. Because in this case, the TAD is oriented like this. And we apply a force in this direction. Okay? The moment, so this is the force to the teeth, this will be the force to the TAD. So this is the moment we apply, what you see here. And you see it's on a plane which is including the long axis of the TAD. Now let's see this very short video. Oh, sorry, I have to get in again. Here we were here.
In this video, we see the activation of a cantilever inserted into the
very
head
boring.
of a miniscrew.
You see how it is?
Activated to give a buckle force vector to the molar and
This is
premolar
the
group
wire
of teeth. Please remark that since the line of action of the produced
in
vector
order to
is
move
parallel to the long axis
teeth
of
to
the
the buckle. Of course,
the moment acting to
people
the
could
screw
say,
does
oh,
not
but there is a
determine
problem
any
applying the force to
unscrewing or
the
screwing of the TAD. Therefore, there is no risk for
to
its
the
stability.
bracket level. This means that you will tip the teeth. No, I mean, you have to know it. Okay? Probably you cannot use this system for more than 1 or 2 millimeters. After that, you have to stop, otherwise your teeth will be very much inclined. But that was just to show you how you can use this. So this is possible. Okay? What is not possible? is to create a moment, as you see here, on a plane which is perpendicular to the orientation of the TAD. Okay? So, for example, if you want to use this TAD to intrude this motor, and you use the cantilever engaged here in this way, you are creating this moment. The TAD will be loose probably in the evening after you've seen the patient. Maybe 24 hours, that's the most. This because you are going to unskew the TAD. But also if you use the opposite moment, okay, let's imagine that instead, in this case, we were intruding the motor. But if you want to extrude the motor, so imagine that you are activating this cantilever like this, activated in this direction to extrude the motor even more. What you would do is to produce a moment in this direction, which is apparently not bad because you are making the screw even tighter in the bone. But this is not good at all because you're probably creating micro cracks of the bone, and this will not become loose immediately, but you have very good chances that in some weeks or 1 month it becomes loose. So don't use moments which are perpendicular to the long axis of the TAD. Okay? Here's another example. If I make an extension in this way and then I apply the force here, this is creating this moment, and what is exactly what I told you. Now let's give a look here to this case taken again from the internet, and this guy was using this cantilever to produce an extrusive force here. But look at the TAD which is inserted here like this, well, oblique but very much transversally. And so when you activate this vertically like this, what you are creating is a moment in this direction which is mostly perpendicular to the axis of the TAD. So there are good chances that in weeks or couple of months this is going to get loose. And in fact this is what happened. And this guy was saying, well, this system of TADs between the roots doesn't work. This is not the problem. The problem is that he was using a moment that shouldn't be used. And there are many ways to avoid it. We'll see this in a while. So this is going to get the TAD loose, but if you are using a TAD in the buccal shelf here, like this, against this force. Now the other TAD was oriented like this mostly, and this is oriented more vertically. So now the moment is on a plane which will not disturb the TAD, and then you have to understand this. It's not just a matter of the bone. Of course, maybe that here in the buccal shelf, here you have a lot of bone here, but it's not only that. Here you need a very special TAD, longer, and I wouldn't do this with the TADs I'm using every day, but there are solutions for this. I mean, it's important that you are not providing the bad moment. So what can we do? Oh, there are tons of solutions for this. So let's imagine that you have a patient with no teeth, no occlusion here, and you want to intrude this incisor. It's a very sad situation. Of course, a patient with no teeth, but it's an extreme situation. And you cannot use a TAD, a single TAD here to intrude this, because if you apply just a cantilever from here to intrude this teeth, you will produce this moment. And this moment will give a load of the TAD which is very dangerous. So this doesn't go. But in this case, if you have bone, you can place two TADs, connect them together, maybe have here a tube. And what happens in this case? In this case, your moment is distributed as you see here. Actually, the single TADs are loaded with forces, not with moments. So the two TADs connected together have never a problem. Okay? So one solution is to use two TADs instead of one. And here you see it. This is a case of mine, a case where this patient came with posterior compression of the condyle. He had a lot of pain. I needed very quickly to create some overjet here. Had a lot of problems, period problems, prosthetic problems, whatever. I couldn't start thinking to place a conventional appliance to all it. So I just needed to apply a force to bring this out and maybe a little bit of intrusion. So I just placed two TADs here, one here and one here, and then one wire that was engaged in the two brackets, and this cantilever, this is beta titanium 1725. Oh. Okay. And you can do anything because we have two TADs. Okay. If you have two TADs, usually it's a good idea to engage the wire in the two slots if you have a bracket head. But even if you don't have a bracket head for some reason, I mean, I have my very good friend Franklin Shea from Hong Kong. Is an amazing orthodontist. He was my student, but he's really great, and he knows a lot of biomechanics. He's a great guy. and he came out with this very nice idea, because at his university they had just to use this TADs with no bracket. So he was creating this wire like this. Now if you activate this wire in this direction, you are getting forces like this. And even if you don't have a bracket where to engage the wire, this system is stable, is not getting out, and you can apply the force using a cantilever system. Of course, a very good way to do it is to use the TAD indirectly. So you just have the one TAD here, you connect it with another tooth, and then you do whatever you like. Okay? This we can skip. Now, you can combine things. So this is two slides I've just added because I made a post on Facebook recently. But to give you the idea of how many things, here I have a single TAD. What am I doing here? I'm using this cantilever here to correct a minimal tendency to crossbite. Actually, you shouldn't go very much out, but make it 1-2 millimeters the most, because otherwise they tip too much, and this TAD is bringing this teeth out, buccal. This is the moment that we are creating to the TAD, but you see it's parallel to the long axis of the TAD, so no danger. And then I'm using the same TAD with this cantilever, which is activated like that, and this is used to move the molar to the mesial. Of course, this is not enough. I also have a TPA, a transpalatal arch, which is moving the molar on the palatal side. And this is going to work for a certain period, then the stud will become loose because the roots are coming in this direction. That's not a mistake. This stud was here for another reason, and I will use it as much as I can. When it becomes loose, I will place another stud here. That's okay. It takes 5 minutes. So, I would just skip this. It's a very technical thing, and we have not enough time, and I want to show you more cases. Just to tell you that the indirect way, I've already told you, it's for me very, very good, a very common way to use the TAD, probably the way I use it most. And what you need, there are different ways to connect the TAD to the teeth to use indirectly, but the best way is to use a very rigid wire, which should be as short as possible, because if it is short, it's becoming very rigid. It's very stiff, and it can limit the movement of your tooth. If it's very long, it's not that good, okay? So here we have a very, sorry, I have to restart here. I made a little mistake. Here we are. Here is just to show you a connection. This is the wire. I cannot draw it because everything is moving. The wire, you see, it's inside the bracket, and I make a ligature as if it was a normal bracket. I mean, you might spend some time to bend this wire so that it's passive. Here is just some composite on top of it, and maybe it takes 5-10 minutes to make this wire, and then to make the ligature. But once you have this will be cut afterwards. Yeah? But once you have this, what happens? That this tooth here, it's becoming your absolute anchorage, and you can do everything you want with this. That's a very special way of using TADs. I call it indirect active use. What does it mean? I'll be very quick because it's a little bit complicated. This mechanics I'm using is bringing the incisor to the palate, and because of the activation of this rectangular loop, okay, and there's another rectangular loop on the other side. So I am using this TAD, this cantilever attached to the TAD to produce the opposite force, okay? And so there is an active use of the TAD, but it's indirect because I'm creating a force not to move the teeth but to prevent the movement. So it's a little bit more complicated, but we have not a lot of time. Considering that we have a little bit more than half an hour, I will go straight to okay, this is usually when I have a break, but I don't give you any break. We have half an hour and we go on with a few cases, and probably I'm just going to show just a little part of the cases that we are having here. So I have a lot of different mechanics for different kind of treatment goal. And let's start with this mesodistal movement. I'm not using sliding mechanics, but if I were using sliding mechanics, what should I do? Well, for example, I would use a TAD connected to this premolar, I start using a coil spring pushing this to the distal, and when the molar is to the final position, I move the TAD here, here, like you see here, and I use another force to bring the other teeth in this. I'm not doing this because I'm not using sliding mechanics, but I use this system with Invisalign. It's the same concept because I'm not using straight wire. For cases that for me are good for straight wire, they are also used for good for aligners. So my choice is between aligners or segmented arch, because for me aligners are the same level as straight wire, and if I need better or better efficiency than this, I go to segmented arch. Otherwise, if I have to do a little thing, of course I can do it with straight wire, but usually people are happier using aligners. So here we have a little thing, and you see this. I place a TAD here, connected, and I make my treatment plan, my clean check, this is an Invisalign treatment, to move the teeth to the distal. And you start seeing the space, and the molar, you see that was, a few millimeters class 2, it gets to a class 1. Once I'm here and I have the space here, now I move the TAD to the posterior, connected here, and then I can move the other teeth back. So you see the difference. There was a class 2 here, more overjet, and I just had to place the TAD. At the beginning was here, then I move it here. And was very, very simple. You can do this for sliding mechanics if you want. I'm not doing it, but it's okay also with Invisalign. Here you can see this video with was my clean check. Here this part is where you see the blue part here is when I connect the TAD to this teeth, okay? They call it precision cat at Invisalign. Okay, here we have a video that we don't see, but we can do much more beautiful thing if you start thinking with biomechanics. I want to show you this case. In this patient, we needed to create the space for this premolar. Of course, you could extract it, but then you would have too much space, and this molar is totally in class 2. Okay, let's see what we can do it. This what we call geometry 6 activation is symmetrical, and we produce two moments which are equal and opposite. Okay, this is not solving our problem. But after 1 month, we place a TAD here and connect it with this molar. So the same mechanics of the TAD starts moving this molar to the distal. This is because this molar cannot rotate at all, or in case there is a little bit of anchorage loss, for sure it will rotate less than this one. And you can reactivate this TPA in this way, as you see here, and nothing is going to happen here. There is a very complex thing that I don't have the time to discuss with you. That is very interesting, that here you're not applying force, only force, but also a moment that brings also the root to the distal. So you see that in a few months, we're talking about 4 months, we have created a lot of space. We're talking about maybe 4 millimeters, and the rest of the space will be created by the rotation and movement of this premolar. And here to show you that the molar that goes to the distal has not tipped to the distal. It's a little bit, we don't have the time to discuss this. Why is this? But it's like that. It depends on the fact that you're using an arch here and not a linear wire like this. But if you're using a TPA, so this arch, when you bring this to the distal, you are also creating a moment in this direction. And depending on this height, you will have a different moment to force ratio. But with the average height of 50 millimeters of this TPA, usually the moment to force ratio is quite good, and we have movements that are similar to translation. Oh, this was good, but was only 1 molar. Let's say what we can do if we want to move a group of teeth. In this case, I would rather use a couple of TADs. One is placed as the other one, as the one we have just seen, just to block this molar. And then I would use another TAD here or here. So in this way, we can produce 2 forces, 1 and 2. And the sum of these 2 forces is probably a big force passing closer to the CR. It's very important that we have these 2 forces, because if you move 1 molar, if you have some rotation, that's not that bad. But if you move a group of 3 teeth, if you have some rotation, you might see the premolar goes in or out depending on the rotation. So you need to have 2 forces to control the rotation. So let's see the case. Also, this I posted this sometimes, I think, in Facebook, but it's interesting to explain this. So you see here we have a class 3 relation between the canine, and we want to send these teeth to the back. As you see, we can do it even in the mandible and even with the second molar present here. And I don't even include the second molar in the mechanics. Here we have not a TPA, but we have a lingual arch, which is not as favorable as a TPA, but you can use it for the same way. So the TAD connected. This lingual arch is pushing in this direction, and this cantilever, this is the cantilever, which produces this force to the molar on the buccal side. So you can see it like this. Okay? I want you to see the difference between the 2 molars. And what happens? You see, this happened in 3 months maybe. Now you see that the canine is more or less in class 1. We have an acceptable intercuspation here. And the position now is not so much different between the 6 and the 7 on the 2 sides. Go back and see. You see? A lot of difference. And the interesting thing is that we have done this for all this group of teeth, starting from the premolar and the 2 molars. So we are creating more space for the canine. Well, there will be a point, if I needed to move this teeth more, what would have happened? Oh, this TAD would become loose because the root gets close and we lose the bone. No problem. If for me that's not a problem because I'm already to my goal, but if this happens, not a problem. I will just place the TAD here. Takes 10 minutes to do it. That's another case which is similar. And here there are many things going on. This mechanics is to move this to the mesial, and this mechanics is to send this to the distal. But again, we have the same system. We have a TAD here connected, the lingual arch pushing to the distal, and a cantilever pushing to the distal. And you can see how we get to the occlusion. Look at this. And now we have a class 1 relation. This is a mechanics to mesialize. We have seen mechanics to distalize. And I think that you can do this bilaterally or unilaterally, but the unilateral is more complicated. So I'm showing this to you, which is more complex. Look, in this case, we have a lateral incisor missing here. I have already placed my canine here. This is a canine, which has already been more or less adjusted as a lateral. But here on the occlusal view, you can see that this is a canine actually. And we have to complete the mesial movement of this teeth. Now, what happens is that we need the activation of the TPA to bring this to the mesial. And of course, if you are activating a TPA, this goes like that. You need to have a TAD to control the rotation. If you don't have the TAD, what happens is that this group is moving like that. It will be awful. But here we have our indirect system. We have a wire here and nothing happens. So I can safely use my TPA to make this movement. And at the same time, have this TAD here, which I also use just to keep the position of this canine there, so I don't want it to drift back. But I use it in which way? You can create this force, but maybe even like this. In this way, you go beyond the CR. Well, you can do a lot of things. Here you see later on, the space is closed, but I'm not very happy because the intercuspation here of the molar is not so good. Again, you can do a lot of things with this. For example, and this has nothing to do with the TADs, but it's always good to talk about biomechanics. If you use an elastic here, you're never solving this problem, okay, or it takes forever. But just use a little bit of thinking, and instead of applying the force at this level, you apply it here, and your elastic will be applied here. So what you're creating, it's a moment, and sorry for this, and you will have a much better occlusion here. But here we are talking about something different. Here we have the molar, which is slightly in class 2, but very little. So in this case, I didn't use the whole, armamentarium. So I had the TAD here that was used before, and I made an activation of the cantilever in this way. Actually, I thought I had the case finished. This case is also in our online textbook for those who have it. I think it's case 100 or 102. You can easily find it, and you see the finished case. And here is another mechanics to close the space. Again, a similar system. The TAD blocking here. See, blocking this molar. The lingual arch moving this in this direction, and one TAD here, where you can produce a force with any direction, and it goes through the CR or even below it. And you see how much space we have done. Also, this case is just finished. I've just finished this case, so I have to place the final pictures. But consider how much space was closed here. So all the space was closed, and the good thing is that we are keeping the overjet without having an inclination of the lower, because I never used the lower front teeth as an anchorage. Now this we can skip, although it could be interesting. This mesialization, I'm going very fast. I know, I'm sorry about that. We would need more time to go into the details. But as you see here, I'm working very much with lingual arches and palatal arches. Here in this case, I dared not to use a TAD. Actually, this case is rather old, and I was not so, I think 2 days I would use a TAD. But at that time, I just said, okay, maybe some occlusal reinforcement here, you might recognize Trigel would be enough. But I have a TAD here connected with this premolars. Actually, it is a very old case because I was not very confident in the use of TADs. Probably this case has been treated 15 years ago or something. Was one of the first cases I was using TADs. And anyway, this TAD is blocking this premolar. I am using the T-loop to close the space. Well, the case was nice because we have closed a lot of space, and now the patient, who is the wife of a colleague, of course, says, I don't want to have the appliance in the front teeth, so we do this. This is the second molar, and see how the space closure is nice, the roots are okay, there's no mesial tipping. But now we can go to the Invisalign, and let me show you. Is there? Okay, go back. You see, this was the molar that it was extracted. This is the 7 and the 8 that we brought forward. Actually, the 8 came on his own. I mean, I didn't band or bond or do anything to the 8. You see the second molar, it's forward and is now tipped to the mesial. And we can do it without stressing the anchorage of this teeth. So this is very nice. This is the case finished after the Invisalign. There is an 180 degrees rotation of this premolar that we left there. Yep, TADs in posterior teeth intrusion. This is a very interesting field, and I'm showing you one case. And we'll just leave this. Okay, I'll only show you. Well, it seems it doesn't work. But I will, let me see if I find another picture. Okay, this is what I wanted to show you. Okay, so if we want to intrude this teeth, and in case of open bite, my suggestion, my recommendation is that you intrude both upper and lower posterior teeth. If you want to reduce a vertical excess of the maxilla mandibular planes, I'm using this system combined, of course, with TPAs and lingual arch to control the transversal. You cannot use this alone, but just a passive TPA or a passive lingual arch, which I mean, if you're used to me, it's a 10 minutes job. I mean, it's very short time. So what I do is that using a cantilever, here we have, let me explain this to you. We have a passive wire, which is this one here. Goes like that. Here is another passive wire. Goes like that. So we are keeping the 4 posterior teeth together from the first premolar to the second molar. Then we have a cantilever, which is this here. And this is activated already. How is it when it's passive, when it's disengaged here? The hook is not here. Let me change the color. Well, you can imagine that this goes something like this. So this 100 gram force is the activation force that I give to the wire. So the TAD is having this force, and the teeth are having this force. Now, we are not using very large forces, as you can see. 100 grams is the most. Then it would be a good idea not to apply this 100 grams immediately. Maybe wait 3 months before using it, or start with even smaller forces. But the problem is that it's very likely that your force is passing mesial to the CR. So this means that you are not really just intruding this teeth, but you are producing a moment like this. So you're producing a force in the moment, and this means that you would see a rotation with more intrusion of the premolars, and maybe the second molar is not intruding at all. And so you are not getting anything for the solution of your open bite because you still have a contact down here. So what you have to do is just to apply a little force at this level. A little force at this level creates to the moment, creates a moment which is opposite in this direction. It's like moving the force at this level. So I'm usually placing a very light elastic between the premolars, and this makes the system work really nice. If you see that for some reason the bite is opening more to the second molar than to the first premolar, it means that you have been applying too much force here, and you might leave the patient without elastic. If you see that the bite is opening only at premolar level, it means that you don't have enough force here, but usually you need very little forces. So let's see what happening. This, I've just described the mechanics. Let's see what happened with this case. Actually, I have a presentation with the whole case, but here we are seeing just this little part. You see the intrusion brings to a closure of the bite, so the open bite becomes less open. But I really like to stress that I don't place any bracket in the anterior. So what you see as a as a closure of the open bite is just a rotation of the mandible, because we have no brackets in the anterior. Sorry, but I would like to show you the whole case. Maybe this lecture will be a little bit more than 2 hours, if it's okay for you. So we see the whole cases. Otherwise, it's not so nice. Now you've seen the mechanics. So this is the case with the open bite you have already seen. I'll be quick anyway. And this is a patient where I've also been working with repositioning. Repositioning is another big topic. We might decide once to make one lecture about repositioning. I don't know. I mean, I'm very busy, so I cannot promise anything in the short term. And this means that we have to control the position of the condyles. And this patient has a very particular shape of her fossa, but you see one thing is very important. The condyle is placed very posteriorly. So here is the whole thing, an open bite of 4 millimeters, an overjet of 8 millimeters, and a class 2. This works great for class 2, this system. So this is the mechanics I have already explained to you. I'm not going to repeat this. You have seen already this picture. And I wanted to show you this. The intrusion is so much that I had to stop in the upper at least, because the TAD was in contact here with the band, with the wires. Look at this. At the beginning there was this space, and now there is not. Someone can think, okay, the TAD has moved, but this is not. You see the border between the attached gingiva and the mucosa is still here. So these teeth have been intruded so much. With intrusion, I've closed a lot this. And using this Tri-Gel, I also control the sagittal of this patient. This is the Tri-Gel. This has to do with repositioning. the profile improves and we get close to a class 1. At the end, you can even use this vertical elastic to improve the occlusion. That's not a danger. See here? And it's interesting, sorry. Okay. It's interesting, you see the change of the position of the condyle. You see here and here. It's more centered. This has to be flipped. I always forget to do it. Anyway, we got to an end. With a class 1. Again, you see the TAD in the upper arch. I mean, we had a tremendous amount of intrusion. I'm using now here a TAD to fix a little bit. There was still a little bit of class 2 here, so I just advanced the canine here, and then I can let the teeth sheet. And here you see the control of the overjet and overbite, which is, remember, she had 8 millimeters overbite here. And there was no proclination of the lower front. So the case at the end, you see I just removed the TAD the day I removed the brackets. And the interesting thing, you see that this the day I've removed everything, a very nice overjet and overbite, I would say. But the interesting thing is the change of, I should take away this. Well, I'm sorry, I can't do it, but this is not my fault. Anyway, you see the difference of the profile, which is very important, and also the difference in the smile. The smile was improved because I did a little bit of extrusion of the anterior. We need it, but we need it for every case. It's different. So sometimes you don't need extrusion of the anterior teeth. Some people come with this condition and have a gummy smile, so don't extrude them. But this lady didn't show the teeth, so we needed to extrude this. But at the same time, her chin is back, so we needed an anterior rotation. So every case is different. So let's go back to the other presentation. And there is another case I want to show you with vertical problems. There are more cases, but I'm just showing you this one. No, don't work, so we skip this one. And I want to show you this one. So this is again more severe than the other one, but it's also completely different, because in this case you won't extrude the anterior teeth, but you still want to have posterior teeth intrusion. So this is a case that she had an arthritis in the past, and this is a very typical case of condylar resorption. And this was not symptomatic, but when you see this face, just imagine that her condyle is not there anymore. We'll see that the CBC later. See, her problem is actually that she is missing the chin, but her chief complaint is she has crowding here. Of course, we are seeing things differently. I told her, well, why don't you do surgery for this? And she didn't want to do it. So I tried to work with intrusion, and I had the first, we had also extraction here. I have extracted the first molar here and the second premolar here, and then the two lower premolars. But I want to, unfortunately I don't have the picture for a first stage where I intruded the posterior, but see this very big step. See, here's the molar, and here's the premolar. So we have already done probably this amount of intrusion of the molar. Now we are working with the mechanics. Very simple, very simple. It's just a force like this plus another force like this, because here is a cantilever which is like that and is activated in this direction. So we are getting more or less this vector. This vector, since the CR, we are working not on the whole arch, but only on the premolars on this side, premolars and canine on this side. So sorry, there are one premolar, two premolars, and the two canines. So as you see, the incisors are kept away from this mechanics. Why? Because I'm going to produce a moment in this direction. And this is fine because I want to see a lot of intrusion here. But if the incisors were included in the system, they would have extruded, and that would be a disaster in this case. So as you see, this wire goes here and connects the two sides, but it's not connected to the incisor. So when this rotates, this tooth, here is the premolar, you see here, and now it's up here, and this is the molar. You see, this step has been closed, and a lot of the space has been closed as well. So we are using the right mechanics. Now, this is not a matter of using the TAD. Yes, the TAD are there and are important, but if you don't know how to use them, if you don't know enough biomechanics, you're not going to do anything with this. At this point, you see that the overjet, when I have intruded this part here, has been reduced, because here I gave to the patient the possibility of rotating. On top of this, here there is some material. This is trigel, so I have pushed the mandible maybe a couple of millimeters more forward. See, the overjet is gone. And I have made extraction in the lower. So here we are uprighting these teeth. Remember that at the beginning, sorry I didn't stress this, but look how these teeth are all of them, they are mesially inclined. In fact, this patient was not in class 2. Look, molar class 1, canine class, almost class 1. The problem is that it's a class 2, skeletal class 2, high angle. The real problem is that one, it's not really the teeth. Now, what we are doing here is the uprighting of these teeth that were inclined like that, and making intrusion of the lower. At the same time, this is a mechanics which is retracting and intruding the upper front. This cantilever is giving to me this force. For those who have followed my previous webinars, this is called cantilever with configuration, and you can give forces of any direction like this. It's very interesting how to use this. This is the case finished. I like it, but the important thing is the rotation we got here, and this is due to the fact that we have done a lot of intrusion at this level. Here's the superimposition, and as you see, there's no fossa here, a little bit here, and this condyle is totally free to move in any direction. So in some way we can even move easily these condyles forward and to improve the aesthetic. These are the CBCT taken a couple of years later after the treatment. Here's her profile. It's not perfect, of course. I'm sure that if she had surgery, this would have been a better case. But without surgery, I think we have done a lot with the use of skeletal anchorage, but more important than this, with the use of the right biomechanics. Okay? So, this is also interesting. But my God, there is no time for everything. So remember that case where I was using a TAD here and a TPA to move this molar distal, okay, when we had this condition here. Okay, this is the same thing. This is the same kind of mechanics, but we're working in another plane. I want you to see this molar, and you can't see it, but this molar is also like that. What kind of movement we need to do with this situation? I mean, if you just make an uprighting with a moment, you will have two level of the occlusal plane with a step, and I don't want it. What you need is an uprighting with intrusion on both sides. Now think about it. When we were working with the TPA, we were getting rotation and distal movement. We can use the same concept on another plane to have the same uprighting and intrusion. So let's see how it works. We have a TAD and we connect it with the premolar. And let's imagine that this Y here, or this Y here, has the same role of the TPA. How do you activate it? So when it's disengaged, it goes like that. When it's disengaged from the anterior, it goes like that. It's like the TPA. It produces at the beginning two equals and opposite moment. But these premolar are not going to upright because they're blocked by the TAD. So progressively you have an intrusive force. It's the same mechanism that brought to the distal movement of the molar on the other case. It's very, very simple. It works. I want you to see this. There is no contact here. There is a little bit of contact here, but the molar is like that. Let's see the X-ray. These are the molar uprighted. Give a look here. Of course, it's impossible to send a band below the bone. But look what happened. Look at the difference. And there was intrusion. And this was a very simple thing. I mean, once you have blocked this premolar with the TAD, this wire requires 10 minutes to be done, and then every time you control, you reactivate. It's very, very fast. You don't have a lot to do to make this. Okay, so we just skip. I'm going just to show you. I'm going to skip this because we are beyond the time. I just want to show you a case about a couple of cases about asymmetrical expansion. We take this one. And this case is again an Invisalign case, just to tell you we can do simple things even with Invisalign if you know how to work. I mean, actually I've seen this patient and she wanted to have an Invisalign treatment, and I would say, okay, what's wrong with this? I mean, we're going to make an expansion. But I was really not very careful. If you see here, there's no crossbite. If you see here, there is some crossbite. So what happens is that in this condition, occlusion is working in this way. So when you expand with the symmetric system, that could be an Invisalign, an aligner, what you get? That you have a nice alignment. Well, that's good. That you have a nice occlusion here, but here is even worse. So I look at this and say, oh my God. I didn't do very well with this Invisalign. You see, it's also good to show you the failures. So I did a second set of aligners, but this time I was smart enough to place my TAD here. And this led to a very nice solution of the case. See? Here, nothing, I just removed the TAD at the end. The molars are okay, and here is corrected. Again, I show you the clean check, but it happened more or less what I was expecting. The fact is that we needed to have control here. So here there was a TAD connected to this tooth. And things were really nice with very little work by my side. Well, this is the last case I'm going to show you, and I apologize for being a little bit late. I apologize especially with my translator that has to work too much for me. No, this is not my last case, but just to show you. You see, you can use the TAD here in the palette in order to make an expansion unilaterally. So, for example, here there is a wire connecting, and then a cantilever which is activated in this way. What are you expecting? That this molar goes out and rotates in this direction. So we can do this. And so that was just a little example. I will show you this mechanics, which is very interesting, and this case was a quite difficult one. This is another case of repositioning. As you see, we start, just then the oral hygiene. We see this lower midline that is corrected by mandibular repositioning. This leads to a cross bite here and almost to a scissor bite here. So my treatment plan was mostly to have an expansion on quadrant 1 and an expansion on quadrant 3. Okay? So I start with what I do most of the time. I use my TAD between the roots. So I place my TAD here, connected, and use my palatal arch to get expansion. But this time didn't work because I didn't have bone. So after a couple of months, what happened is that I didn't solve anything here, and these are even worse. Why? Because here occlusion is giving forces in this direction. Here occlusion is not working, so the expansion went only in this direction. Wow, that was great, wasn't it? Look at this. So I was very, very worried, and so I decided, okay, it's about time to use the palatal system. And this was a case where the bone here was really very, very bad. So I didn't even try to put it a second time. I went directly to this. So I have to start correcting, especially this position. But look at the canine. Do you want to contract this? No. Huh? In fact, this is the scissor bite here is here, but it's not here. So what we need is a contraction, but also some rotation. This means that we need that this line of action of the force, as you will see, is not passing through the CR. So that it creates this moment. And this moment is needed because I want to expand the canine and I want to contract a lot the molar. So what happened? Okay, here we are. And that's what happened. Look at the canine. You see that the canine has expanded a little bit. Compare it with the lateral. The lateral has no brackets, so we didn't move it. And look at the molar compared to the second molar. Now it's aligned. We can see it better from here. This is not here anymore. And now I will use the same tabs to do the expansion on this side. So I had just to use this arch. So before I had an arch that was contracting. Okay. Now I have an arch that is expanding. So it's like that. So let's see the whole story. So this is at the beginning. Oh, sorry. This is at the beginning. This is when I've lost Anchorage and went almost in scissor bite. This is when I've corrected the scissor bite. This is when I've expanded for the second stage this part. And this when it was over. So the mechanics on the palatal side was very, very effective. Of course, this is more complicated because to do this stuff, to me, it takes more time than placing a tad here and expanding the arch here. But if this doesn't work because we have no bone, well, I spend more time and I do the right thing. It's okay. And I think that from here to here, there's a lot of work and a lot of work about moving this teeth in this direction and this teeth in this direction. And of course, this cannot be done without skeletal anchorage because it's totally impossible. There's no way you can treat the case like that. So this is the whole case. I mean, there should be, again, a lot to speak about repositioning here. You see we started in class 2, we're finishing in class 1. Is the case finished with the midlines that are on? He will have surgery to improve the gingival contour here. I think it would be much better if we do something like that. And here you see the condyles that have been advanced on this side to correct the asymmetry. And here is, I think, this picture has done already the surgery. Okay, there are more materials, but we are definitely over time. So I thank you. I don't know if there are questions. I mean, you can ask Leo, to our interpreter, and then I'm waiting for questions. Okay, so just let me know if there are questions or anything. Otherwise, I'm thanking you for your attention and greeting to you. And this means that you are over with these webinars. In case you want to contact me, this is my email. Of course, you can also get in touch.com. So, okay. You can also get in touch with me through OHIS, no problem. So, Leo, let me know if there are questions. I'm just waiting here for a few minutes to know whether there are questions. It seems no question. Okay, so thank you everyone, and I wish you a nice evening, a good night, and hope to have the chance to meet you again. Take care. Bye bye.